Are you blaming arthritis, your hip going out, or simple wear and tear whenever you feel that deep, nagging hip pain? What if the real reason is something almost no one checks for? A hidden cause frequently misdiagnosed as bursitis or back pain, yet completely treatable when caught early. Today, top Mayo Clinic hip surgeon Dr. Rafael Sierra reveals the one diagnostic sign he never lets his residents miss. A single clue that can literally change how your hip functions for the rest of your life. And here's something you can try right now. Stand on one leg. If your pelvis stays level but your hip feels like it's pinching, shaking, or struggling to stabilize, that's actually more consistent with a tendon problem than arthritis. Most people, and even many clinicians, don't recognize that difference. It's tiny, but shockingly accurate. Before we go on, here's a small gem. If your hip pain feels worse when you walk downhill but not so much uphill, that pattern is far more linked to abductor insufficiency than arthritis or bursitis. It's one of those subtle signs that most people never think about. Before we dig in, quick intro. Dr. Rafael J. Sierra is a hip and knee reconstruction specialist at the Mayo Clinic in Rochester, Minnesota. He's a division chair and a global researcher in hip preservation, abductor, gluteal insufficiency, and femoral head problems. Fields that focus on saving native hips before they need replacement. His published work and clinical programs focus on diagnosing subtle hip disorders that often hide behind common symptoms. Later, I'll show the one simple movement test Dr. Sierra says trips up nearly every misdiagnosis, and why it's more revealing than an X-ray. The hidden culprit, abductor, gluteus medius/minimus, tears and insufficiency. Here's the big reveal. The cause many clinicians don't check for is abductor insufficiency, damage to the gluteus medius or gluteus minimus tendons, the hip's rotator cuff. When these tendons are torn, degenerated, or have fatty infiltration, the hip can no longer stabilize the pelvis during walking. The result? Deep lateral hip pain, limp, difficulty with single leg stance, and symptoms that are commonly mistaken for buccenteric bursitis or even lumbar referred pain. Mini payoff. Here's a small but powerful clue. If the pain gets worse when you push off the ground to walk, not when you put weight down, that pattern almost always points to tendon involvement, not arthritis. Why is it missed? Because standard workups often stop at X-rays, which show arthritis, or basic exams that focus on the spine. The abductor tendons require a targeted clinical exam and often MRI or ultrasound to detect tears or fatty change. Tests not always ordered in routine hip pain visits. I'll demonstrate the test in 30 seconds, and you can try it at home, but don't self-diagnose. This is educational. How patients describe it. Real symptoms. Patients often describe sharp or burning pain on the outside of the hip, pain when lying on that side, trouble climbing stairs, and a feeling that the leg gives out during single-leg tasks. Unlike classic arthritis, they may be younger, active, and have a focal point of pain rather than widespread joint ache. Many have been labeled bursitis for months with repeated steroid shots that don't fully fix the problem. Mini payoff. A quick at-home hint. Press gently over the side of your hip. If the pain shoots outward rather than deep inside the joint, that's another strong indicator you're dealing with the abductors. The quick clinical test. Trendelenburg plus the broken wing clue. Here's the clinical pearl Dr. Sierra teaches. The Trendelenburg test. Ask the patient to stand on one leg. If the pelvis drops on the opposite side, that indicates abductor weakness. But Dr. Sierra takes it further. Look for subtle compensatory gait and weak resisted abduction. Recently, orthopedics has added more specific signs, including a clinical finding being discussed in recent research nicknamed the broken wing sign, that correlate with fatty degeneration and worse tendon disease, meaning the problem isn't just a tendon pain, it's a failing stabilizer. Mini payoff. Even if your pelvis doesn't drop dramatically, a slight trunk lean toward the standing side is a giveaway Dr. Sierra tells his residents to watch for. It means your body is cheating for weak abductors. If the Trendelenburg is positive, the imaging you order next will change everything. Don't miss this. Imaging, what to order and what to look for. If you suspect abductor problems, request an MRI of the hip with dedicated tendon protocol or an ultrasound by an experienced musculoskeletal sonographer. On MRI, radiologists look for tendon tears, partial thickness injury, and fatty infiltration of the muscle, a sign the muscle has been chronically injured. These changes can be subtle and are sometimes missed on routine MRI reports that focus on cartilage and labrum. That's why Dr. Sierra emphasizes direct communication with the radiologist and specific imaging requests. Mini payoff. On MRI, look for this phrase, fatty infiltration. It sounds scary, but here's the payoff. Catching it early means exercises and injections work far better. That single line in a report changes the entire treatment plan. There's one imaging detail, fatty infiltration, that predicts whether surgery will succeed. I'll explain that in plain language next. Treatment options. From rehab to repair. Treatment is staged. Conservative care first, targeted physical therapy focused on abductor strengthening, gait retraining, hip core work, and activity modification. Many people improve with a well-designed program. Injection therapies. Ultrasound-guided corticosteroid for associated bursitis, or biologics like PRP for tendon healing, selected cases. Surgical repair for full-thickness tears or persistent pain after conservative care. Tendon repair, open or endoscopic, can restore function. In chronic cases with severe fatty infiltration or abductor deficiency, reconstructive options such as tendon transfers or augmentations may be considered. Dr. Sierra's research includes strategies to restore abductor function and prevent failure after hip replacement or revision surgery. Key point: timing matters. Early detection before extensive fatty change increases the chance that non-operative care or repair will succeed. Once the muscle has degenerated, outcomes are less predictable, which is why the diagnosis shouldn't be delayed. Later, I'll show 2 quick home exercises you can do safely to start strengthening your abductors. No equipment needed. A short case example. Meet Sarah, a 42-year-old runner with 9 months of lateral hip pain. She had 3 cortisone shots and an X-ray read as normal. On exam, she had a subtle Trendelenburg and pain with resisted abduction. MRI with a tendon protocol showed a partial thickness gluteus medius tear with early fatty change. With 12 weeks of targeted rehab plus a PRP-type injection, her pain dropped by 70%, and she returned to running at 4 months. Early diagnosis changed the whole trajectory. Mini payoff. For Sarah, the game changer wasn't the MRI. It was the first time a doctor actually checked her abductors. One small clinical test changed 9 months of frustration. What if she'd waited 2 more years? The options and success rates would have been very different. That's why this hidden cause matters. Prevention and 2 simple exercises you can start today. Prevention focuses on movement quality and glute strength. 2 safe starter moves: side-lying leg lifts, controlled. 3 sets of 12, focusing on slow, pain-free range. Band walks, mini band lateral steps. 3 sets of 15 steps each direction. Keep knees slightly bent and core engaged. Do these 3 times a week. If you feel sharp or worsening pain, stop and consult a clinician. Strengthening early can reduce overload and reduce the chance of progression. Mini payoff. If you feel a burning fatigue on the side of your hip during these exercises, that's a good sign. It means the abductors are finally firing the way they're supposed to. When to see a specialist and final takeaways. See a hip specialist if you have persistent lateral hip pain, greater than 6 weeks despite home care, a limp, difficulty with single-leg tasks, or pain that wakes you at night. Ask your clinician specifically whether abductor tendon disease has been considered. Request an MRI hip with abductor protocol or an ultrasound. Remember, early recognition is the game changer. If you found this useful, like, subscribe, and hit the bell. We'll keep bringing expert-backed tips. Big thanks to Dr. Rafael Sierra and teams doing the work to identify conditions that hide in plain sight. This video is educational, not medical advice. Always consult your doctor before starting any new treatment or exercise.